And now it is my great pleasure to introduce my friend, Dr. Jason Silverstein. Dr. Jason Silverstein is currently part of ChristianaCare Neurology Specialists and is director of the Comprehensive Multiple Sclerosis Center of Excellence at ChristianaCare Hospital. He is also the clinical lead for the ambulatory neuroscience practice and associate physician executive for the neuroscience service line. Dr. Silverstein received his undergraduate training in biology at Arcadia University and later received his DO degree from Lake Erie College of Osteopathic Medicine. He completed his neurology residency at Drexel University College of Medicine, where he serves as chief resident. He then completed a neuroimmunology fellowship at the University of Texas Southwestern, where he was a recipient of the National Multiple Sclerosis Fellow Award. Dr. Silverstein sits on the National Comprehensive Multiple Sclerosis Center Review Committee for the National MS Society. He also serves on the Delaware Medical Marijuana Oversight Committee. In recent years, he has started a neuroimmunology clinic at Nemours Children's Hospital, where he evaluates and manages pediatric neuroimmunology diseases and educates their neurology residents. The ChristianaCare MS Center conducts numerous clinical trials in the area of multiple sclerosis therapeutics. In addition, Dr. Silverstein began the first MS multidisciplinary monthly clinic in the state of Delaware. Today, Dr. Silverstein will discuss the latest updates in the field of multiple sclerosis. Dr. Silverstein.
Mouthful, man. Thank you very much. I appreciate that.
My pleasure.
Yeah. So let me share my screen here. Okay. Let me know when we're all good.
Yes, we can see.
Perfect. Okay. So we're going to have a chat today about just on a high level updates in MS to touch on some maybe newer concepts, philosophy of care in MS. So here are my disclosures. So, the definition of MS, I think, has changed a little over the past 50 years. It's probably still best explained as an autoimmune disease with variable phenotypic expression. As we all know, it can manifest in many different ways. It can look very different, but it's punctuated by a neuroinflammatory as well as neurodegenerative aspect or feature that we believe occurs in genetically predisposed individuals, likely secondary to some sort of trigger. And that trigger seems to be environmental, as we'll touch on. So, busy slide, but I put this up there for two reasons. One, to show the complexity of what's involved in the immune system. You can see the blood-brain barrier in the middle, and then below it is in the periphery, above it is in the CNS. So you can see the complex nature of interactions. And of course, we know a small percentage of what actually goes on. And for anybody that has been practicing for more than 20 years and has seen MS patients knows that it was once thought that T cells were, for the most part, the only cells that were driving this disease. We now know very different. So we know there's all different types of T cells, but we know very well that B cells also get activated in the periphery, make their way through the blood-brain barrier, and B cells in the CNS both secrete antibodies that are pathogenic, as well as activate, Th1, inflammatory cells. The other part that I'll just mention here that is clear is that MS is not just about the adaptive immune system. So it's not just about T cells and B cells. We know very well that the innate immune system is involved as well. And that includes macrophages, that includes natural killer cells, and in particular, microglial cells that can act to help reactivate T cells in the CNS, but also themselves secrete inflammatory cytokines leading to neuroaxonal injury. But the disease is, as I said, punctuated not just by inflammation, but there's definitely a neurodegenerative aspect as well. And I would say, although these two are related, meaning the more inflammation you have that seems to lead to neurodegenerative process, it is certainly independent. So neurodegeneration seems to be an independent process from inflammation. And what this is really just pointing out, you can see in the bottom left, it's pointing to the mitochondrial. So we know mitochondrial dysfunction occurs in MS, leading to neuronal death. In the bottom right, we know that due to inflammatory damage to the myelin and axon, we know that there's a dying back phenomenon. There's neuroaxonal injury that occurs. And then, of course, we all know that when there's myelin damage, this leads to replacement of the existing ion channels, particularly sodium channels, with sort of, I don't know, ersatz type channels, meaning kind of fake versions of the real thing. And these ion channels a lot of times don't work as well, and over time can become dysfunctional, leading to further axonal injury. And if anybody sees MS patients, they know very well that some of them are very sensitive to temperature changes, particularly heat, but sometimes cold. And if you wonder why is that, well, one proposed reason is that these ersatz channels, sodium channels that are replaced in areas of previous damage, they are very temperature sensitive. And so when you heat up, they just don't work as well, affecting the propagation of the action potential. But the one I wanted to point out, and this certainly may come across as maybe a theme for this discussion, is we know in the top left, we know that microglia are quite involved in the neurodegenerative process in MS. We know there's different types of microglia, but microglia can be homeostatic, meaning they're nice, they support normal function of the surrounding neurons and axons. But microglia have pathogenic versions that when they get activated, they can secrete pro-inflammatory cytokines. They can activate Th1 cells, leading to further neuroinflammation. So almost in a smoldering way, like a house fire that goes out and then there's just embers there for a couple of days. Microglia seem to kind of lead to some sort of like burning, smoldering inflammation. So this is a classic pathology of MS. On the left, you can see perivascular cuffing or perivascular inflammation. You can see lymphocytes surrounding a central vein. And then on the right, you can see that there are juxtacortical white matter lesions, which on the bottom part, you can see the blue is a Luxel fast blue stain, which stains myelin. And then you can see the central kind of pale area is the area of demyelination with what look to be large macrophages that have lipid in them. So they're called foamy macrophages or lipid macrophages because they are eating up the damaged myelin. So that is the classic kind of pathological view of MS. On here, on the top, A, what we believe happens is there's in the periphery, we believe there's some sort of immune response. We believe T cells become activated and autoreactive against some sort of antigen. They make their way into the CNS through different mechanisms, through the blood-brain barrier, leading to CNS inflammation. Now, of course, there's then injury, right? Injury to myelin, injury to axons, which then we believe leads to neurodegenerative processes like ion channel dysfunction, activated microglia. But the bottom, what happens when there is this damage and then you have sort of this debris that may be released is that the idea is that with neurodegeneration and release of parts of axons and myelin, you can have a secondary immune response to this as well, then further leading to CNS inflammation. And this is a picture I always like showing because it makes you think about whether MS is, as most people think and would say, MS is an outside-in phenomenon, meaning, like I said, the lymphocytes get activated in the periphery, make their way in, and lead to CNS inflammation and subsequent degeneration. There are a small percentage of people who believe that maybe MS is not. Maybe MS is an inside-out phenomenon, meaning the primary problem is neurodegeneration. And with release of debris, you get a secondary immune response leading to further CNS inflammation. And that's what we see when we do MRIs looking at, see gadolinium-enhancing lesions. And so this picture, if you didn't know anything and you look at this picture, you'd look at that and you'd say, oh, it's a train crash. And we would all say like, oh no, the the people with the orange suits and hazmat, all that, they're there in response to the crash. But how do you know that these people didn't actually cause the crash? So it makes you think, what we're seeing in the CNS is damage. Is it being done by the immune cells, or are the immune cells there in response to some primary damage that has happened? That's certainly controversial. Most people would say those people came in and they did this damage, like your immune system came in and did the damage. That's the prevailing theory, but there are some that believe in the inside out hypothesis. So like many diseases, this disease has a spectrum to it. On the bottom there, you can see the classic definite, multiple sclerosis subtypes or phenotypes. So you have the classic relapsing remitting, and then you have progressive subtypes. Secondary, where these individuals typically have a relapsing course for 10 to 15 years, and then begin to show signs of definite, progression or worsening of some function. And then you have those that just seem to be progressive from the beginning, primary progressive, which is a smaller subset, maybe about 10%, seems to be maybe a little more common in men than women, whereas MS is obviously more common in women in general. When an individual doesn't meet criteria, but they've had their first attack, say optic neuritis, we call that a clinically isolated syndrome. I think with updated criteria for MS, including more sensitive MRI criteria, the number of patients that are really CIS, clinically isolated, that don't meet criteria, certainly I think has diminished. Then what do you do with those people who have just kind of like maybe a headache and they end up getting an MRI, and lo and behold, they have classic demyelination. And then you go ahead and do spinal cord imaging and you find there's actual spinal cord demyelination as well, but they've never had any symptoms referable to demyelinating disease. So we call that radiographically isolated syndrome. Some call it radiologically isolated syndrome, RIS. But then there's an interesting part of the spectrum that has been called prodromal MS. And this is not unique, obviously, to MS. You can see this in other disease states as well. And the idea is, in the time period of MS, you have the classical off to the right, the classical symptom onset, optic neuritis, transverse myelitis, they meet formal criteria. Then you go all the way off to the left and you have this at-risk period, meaning maybe genetics are involved, mom has MS. We know, as I'll talk about, Epstein-Barr virus seems to be a very significant risk factor. Maybe sunlight, low vitamin D. So you have that period. But we know that when you look back, and there's been some recent studies looking at patients with MS, and you look at medical records and you go back 10, 15 years, we know that there's an increased amount of office visits for these patients before they were diagnosed, increased rates of fatigue, headaches, pain, depression, higher rates of visits to the hospital, and I said higher office visits. So we call this the prodromal phase, meaning there may be this phase where the biology of the disease has been established, right? There's been a trigger. The immune system has been become autoreactive. The biology has begun. Immune system has caused CNS inflammation. It's all ongoing, but they haven't yet really manifested with a classical attack, but yet they're having some sort of subtle symptoms ongoing. We call this the prodromal phase. Certainly challenging to detect because, quite frankly, a lot of these symptoms are nonspecific. But as we get more sophisticated, if we can catch people in this prodromal phase, maybe we can further continue to get better at modifying the disease course. So this is a classic graph of the disease course. Off to the left is the subclinical, maybe you call prodromal. And then a monosymptomatic, the initial demyelinating event, then you're relapsing, remitting, and potentially become progressive. And what we all know is that when we think about the early stages of MS, we think about relapses, the green arrows here. So relapses are way more common in the early stages of the disease, certainly in the first 10 years. As you get older, relapse rates certainly become more sparse. They definitely decline. We know that cognitive dysfunction and brain atrophy increase with time. But the thing I want to point out here in the disease course So in yellow, you can see the cognitive dysfunction, which you can see increases over time. And then you can see the dotted square white line, and you can see that that's the brain volume decreases over time. And what we know is even in the earliest stages of MS, and I'm talking about potentially even prodromal, but certainly after the first attack, we know neurodegenerative processes are ongoing in many patients. And we know brain atrophy rates are higher. We know that there already is evidence of cognitive dysfunction in early stages. So, you know, you once thought that MS, disability, progression, that happens later on, right? In secondary progressive. We know that's not true. We know progression happens in some patients very early on. And the term that we're using for this now, or some have used, it's called PIRA. So it's called progression independent of relapse activity. So these are people who, as you can see in the graph here, they have a relapse, increases their level of disability, then they recover to whatever degree, maybe full, maybe partial. But then there's a period where they're not having any abrupt new symptoms. But when you actually look closely in some of these people, you assess their daily functioning, you assess their walking, you assess their upper extremity function, you can see that some of these people are having a very subtle change or decline in function outside of an actual relapse. So we call that progression independent of relapse activity, or silent progression. We know this occurs early in the disease. In fact, studies have shown recently that much of the disability that patients with MS accrue in relapsing disease in the first 15 years is actually occurred through PIRA, silently, where they just have this subtle change. They have more fatigue, they have more walking issues, but they didn't actually have an attack. So we know that there's some sort of process that drives a silent progression in both relapsing forms as well as progressive phenotypes. So this implicates some sort of central neuroinflammation. Maybe some have called it inflammation happening behind closed doors, meaning behind the blood-brain barrier. Some have called it compartmentalized inflammation because it's compartmentalized the CNS. And then probably the buzzword now maybe is smoldering inflammation. This idea that there is a smoldering inflammatory process happening, not enough to show up on GAD-enhancing lesions, but there's a process happening that leads to a silent progression, neuroaxonal injury. And that's where, again, I think the theme comes in about microglia. There is continuing to be strong evidence that microglia can become activated, pathogenic, and can release inflammatory markers like cytokines, can certainly recruit immune cells, usually Th1 cells, causing further neuroaxonal injury. And this is what we call smoldering inflammation. And you would say, well, can you see it on MRI? And I would say, on a conventional MRI, that's a 1 or 1.5 Tesla, you're probably not going to see it. If you have a 3 Tesla and you're doing susceptibility weighted imaging, which really looks at hemosiderin and iron, you can see what are called rim lesions. You can see that there's a rim of hemosiderin. Iron deposition you can see around certain lesions. We know iron gets deposited as an effect of microglia causing inflammation. So you can sometimes see this on imaging, but in general, you're not going to see this subtle process that's actually happening. So what are the cause, right? Patients ask this all the time. What is the cause of MS? How can I modify it? How can I change it? Obviously, there's been for a long time evidence of a latitudinal risk. The further away from the equator, it seems in general the incidence and prevalence of multiple sclerosis is higher, and so that's been replicated fairly well in epidemiological studies over the past 50 to 60 years. We have linked low vitamin D to MS, although low vitamin D has been linked to a number of disease processes, so I'm dubious that is truly a trigger. Obesity, smoking tobacco, gut health, or the microbiome has been a buzz and a big topic for the past 10 years. Is it possible that there's some change in the milieu of the bacteria and even parasites and that do interact quite a bit with the immune system? But the big one that I'll mention is not new, but I think that has stronger evidence to support it, is Epstein-Barr virus and previous infection. So we know that if one has had Epstein-Barr virus induced mononucleosis, so infectious mono, their risk of developing MS is 3 to 3.5 times higher. And we know that it's rare to see a patient with MS that does not show serological evidence of exposure to Epstein-Barr. So that's not new, right? I mean, the viral theory of MS goes back to the late 70s. Lots of viruses have come and gone as being proposed to be related. In fact, I think it was sometime in the late 70s, early 80s, there was like a buzz that the virus was found that causes MS, and it turned out to be crap and didn't really work out. But Epstein-Barr virus has persisted since the late 80s, early 90s as a potential trigger. And then last year, there was, I would say a landmark paper out of Harvard that was a longitudinal analysis looking at the prevalence and potential causation of Epstein-Barr virus and MS. So what this study did, it was published in Science. So they looked at the database of military recruits, which is a great database because they come in young, 18 years old. They're generally in their 20s. And they looked at these active duty military from the 1993 to 2013. And these military recruits get blood samples every 2 years. So in the Department of Defense Serum Repository. So they were able to go ahead and, okay, look at these active, this cohort, look at patients that were eventually diagnosed as MS, which are around 800, and they compared them to some matched controls. And they were able to go back and look at these blood samples that were done every 2 years and actually look at a couple things. Look at serological evidence of exposure, so antibodies against Epstein-Barr virus, so the viral capsid antigen, the nuclear antigen, to show exposure. And they were able to actually interrogate the samples and looking for what's called neurofilament light chain, which is an aspect of axons. There's light chain, there's medium chain, there's heavy chain, intermediate chain. Light chain is one that we'll talk about, has been definitely associated with risk of relapse in MS and associated with axonal injury. So this study basically showed that if you showed exposure to Epstein-Barr virus, which universally almost all of the MS patients did, your risk of developing MS was 32 times higher. So that's, it's notable, but that's not necessarily anything new. Like, we've known that exposure increases risk, and there wasn't any other association with other viruses. But the interesting part of this study is what you saw, that the first thing you saw was that they show exposure in their serum to Epstein-Barr. Okay, they're not diagnosed yet. The next thing you saw in this cohort of patients that would develop MS is you saw neurofilament light chain levels increase. So then they go up after exposure, and then on an average of 2 to 3 years later, then they're diagnosed with MS. So it's the first study showing maybe the biological evolution of this disease, like a trigger, viral exposure, then evidence of neuroinflammation, axonal injury, and then they're diagnosed with MS. So this is probably the biggest study to show that this seems to be, it's not causative, never would say that. 95, 98% of the population is exposure to Epstein-Barr virus, so it can't be causative, but it seems to be a notable trigger, very important, maybe. Genetics play a role, but even twin studies will show you that it's not the whole story. Even twin studies, contemporary twin studies, show a concordance rate maybe of 60-some%. So if one twin has MS, maybe the risk is 60-some%, right? So it's not 100%. So it's clear that this is not a purely genetic disease. There's been over 120 or more now gene alleles that have been associated with increased risk of MS. And the one thing I want to point out on this slide is, as I said earlier, The innate immune system is clearly involved as well. So you can see that there are genes that are involved in natural killer cells and microglia, macrophages, that these genes are seen to be associated as well. So it definitely is not just the adaptive immune system involved in this process. So biomarkers are becoming a big story here in MS. We're always looking for a way that we can better diagnose the disease, better monitor the effect of our treatments, and monitor for progression. There's a number of biomarkers that are being looked at. GFAP, glial fibrillary acidic protein, is one, but the biggest one right now is serum neurofilament light chain. It was looked at in CSF first. Now serum looks to be very valid measure or biomarker. So it definitely correlates with relapse rates, disability worsening, new MRI activity. It even correlates with, on OCT, looking at the retinal nerve fiber layer, it correlates with reduced thickness and atrophy in the brain. And as I said earlier, the neurofilament light chains, you can see you have myelinated axons, and the axon itself has different size neurofilaments. And so when there's injury to the axon, you can imagine these neurofilaments are released as debris, and we can detect them in the serum as a measure of axonal injury. So at our just recent meeting, at our ECTRIMS meeting, European Committee for Treatment of MS in Milan, there was a poster presentation looking at two large MS databases, over 2,000 patients. And what they were looking at assessing clinical disability worsening, okay, every 6 months, looking at disability worsening, either with a relapse or without a recent relapse. So that would be the PIRA or silent progression. What was interesting, as I said earlier, most disability in these patients actually seemed to happen without a relapse. So their EDSS, their disability score, seemed to increase, but there was no recent relapse in the past 6 months. So that was independent of a relapse. But what was interesting was they correlated neurofilament light chain levels with this disability. So NFL levels increased about a year prior to disability worsening if it was due to a relapse, almost as if it was somewhat predictive. You could see that the levels were increasing from baseline. But even up to 2 years before, they're showing signs of disability progression outside of a relapse, meaning silent progression. You could even see 2 years before there's evidence of rise of the neurofilament light chain levels. So that begs the question, you know, what could the future use of biomarkers, whether it's NFL or GFAP, there's a whole bunch of them. What could that be? Well, obviously it could assist with diagnosis, right? If you have a patient who has vague symptoms, we've seen them all, right? Fatigue and headaches and weird pains, and they certainly don't meet classic criteria for MS, but what if you have baseline NFL and you're seeing that there's an increase over the next year or two? Maybe it could assist in diagnosis. Once you're started on treatment, could it help us monitor DMT efficacy, right? And so certainly might be concerning if their NFL levels are increasing above baseline despite being on DMT. We can monitor for disease progression as well. That would be very helpful. The other one that might be interesting, of course, is you have a patient who is 55, 60 years old, who's doing very well, and they're on treatment, but we have discussions all the time about discontinuing said treatment and simply monitoring them because they're at the stage where, neuroinflammation, new attacks certainly significantly reduced. But could you use a biomarker to say, hey, look, let's get a baseline. Let's come off treatment. And every 6 months, we're going to check NFL. And if we see it going up consistently, maybe could that be a valid way to say, that's a problem. Maybe we should rethink remaining off treatment. So this is the most updated diagnostic criteria, McDonald criteria in 2017. It remains unchanged with the idea that if somebody has 2 attacks, optic neuritis and numbness in their legs, separated in time, that meets criteria as long as you rule out anything else. The way this criteria changed to make it more sensitive to make the diagnosis is where you see it says clinical attacks 1, clinical signs 1. So that would be somebody who, let's say, has vertigo and double vision, let's say, and they have some nystagmus. This is where they've had one attack. We can diagnose MS with, at that time, simply with just one MRI. And the way we can do that is we can show dissemination in space and time simply on just that one MRI. How do you do that? Well, the MRI, as long as it shows 2 or more classic T2 lesions in typical locations like periventricular, juxtacortical, infratentorial, corpus callosal, cortical. So it just has to say 2 in different locations. That means dissemination in space. And dissemination in time would be the presence of 1 enhancing lesion and at least 1 non-enhancing lesion. So evidence that there's a new one and there's one that's old. If you could show that on the baseline MRI, you meet dissemination in time and space, and they've had an attack, you can make the diagnosis right away. The other change that I'll mention is CSF now can be used for dissemination in time. The logic behind that is that, it's thought that these oligoclonal bands, clone of lymphocytes pumping out, antibody, doesn't happen overnight, right? Takes time for these B cells to get activated and to produce antibody. So you can have one clinical attack, but you have another sign on exam. Maybe they have weakness of the right leg, but their attack was optic neuritis. You have to show that there's a dissemination in time in that case. You show space, weakness and optic neuritis, but you can use CSF to say, there's bands, dissemination in time. So that's the big change, is CSF dissemination time, and we can use MRI to meet DIT and DIS as well. Early intervention has been borne out to be important in many clinical trials now, as well as in observational studies. The idea is that you have an attack. If you intervene right away, start a DMT, and you compare that cohort to people that are delayed treatment, even by 9 months to a year, what you consistently see is the group that's delayed, the later intervention group in gray here, you can see they don't catch up. You can see that over the next several years, on average, that cohort's level of disability, even the rate of relapse, is higher than the group that you intervened with early. And so it points out, like, time is brain, right? Much like in the vascular world, everybody accepts now that it's probably a good idea to intervene as soon as somebody has their onset or ictus of stroke symptoms. We should be thinking the same when it comes to demyelinating disease as well. And this will be the same, no doubt, in other neurological diseases for sure, where early intervention is going to be the key. It's just you got to be able to diagnose it as early as possible, so that way we might be more successful. So in this talk, I'm not going to go through, obviously, any of the DMTs in great detail. There's over 20 of them now. So I break them into categories. You have injectables, you have orals, and then you have parental or infusion therapies. Some of our drugs are immunomodulatory, like the interferon drugs and Copaxone, right? They're not suppressing the immune system per se. They don't increase risk of cancers or infections. Then we have most of our drugs that are immunosuppressive, right? So they, like most of the oral drugs, like the sphingosine 1-phosphate drugs, like Gilenya and Mayza and Zeposia, Tecfidera, Tysabri, Ocrevus, infusions. But then we have drugs that are immune depleting and then lead to sort of a immune repopulation over time, or what's called a reconstitution. And currently 2 of our drugs fall into that category, and that would be on the orals. That would be Mavenclad, oral short course therapy, also called oral cladribine, previously used at high doses intravenous for hairy cell leukemia. And then infusion, that would be Lemtrada, with the 2 stars next to it, or alemtuzumab. So these 2 drugs are very different than our other therapies. They're not maintenance therapies. They are given in short yearly courses, leading to a profound depletion, dare I say, elimination of certain populations of lymphocytes, and also to some degree, some innate immune cells to a lesser degree. And then with a subsequent repopulation or reconstitution over the next year. And the idea is they're almost like poor man versions of hematopoietic stem cell transplant. It's like a mini reboot of parts of the immune system. The idea is to eliminate autoreactive cells, and they get replaced with cells that are more tolerant of self. So we're moving and inching more with our DMTs to being more immunodepletion and trying to eliminate the aggressive cells. The one class of drugs that I wanted to bring up that's not yet approved, FDA approved, but has at least 5 drugs that are in, some of them in late stage clinical trials, is a group of therapies called BTK, or Bruton's tyrosine kinase inhibitors. Not a new class of drugs. These were approved in the oncology world for CLL and small lymphocytic lymphoma and Waldenstrom's. I believe goes back to 2000s where they were approved on the market, maybe 2010 or 11. So these would be the first enzyme-based MS therapy, right? Most of our drugs are, interfere with DNA synthesis. They're purine or pyrimidine analogs. Maybe they block migration into the CNS, like Tysabri. Maybe they block or trap immune cells and lymph nodes, like the S1P drugs. But BTK is an enzyme. And so that's an enzyme where in the MS field, we got to start getting comfortable again using terms like covalent and non-covalent binding and irreversible and reversible. These are things that I don't think we have typically talked about in the MS world. But these drugs are interesting because, again, this ties into the theme maybe here in this talk. BTK enzyme is important in 2 groups of cells in particular. It's very important in B cells, which is why we think it's seems to be highly effective in relapsing, remitting MS. So it's very important to activate B cells, to proliferate. It's helpful for and important in the process of antibody production. But BTK enzyme is also present in high amounts in microglia. In fact, the BTK, enzyme is very important to activate microglia. When they get activated again, they can stimulate Th1 cells and can release inflammatory cytokine. And so BTK is involved in this process in activating microglia. So there are ongoing trials in both relapsing disease as well as in progressive disease. I think that's where the interesting part is could this deactivate microglia, reducing some of what I call the smoldering inflammation that's leading to CNS inflammation and potentially a silent progression over time, or what we call PIRA. The most frustrating part of MS, right, for any of us that treat MS, is these people's, some of them, inevitable decline despite our best efforts. So, you saw that list of DMTs, and the question would be, well, how do you go ahead and choose a DMT when there's like 20 some options, right? As I'll talk about, shared decision making is really, really, really important. It's the way you should be doing this. I don't think we should be giving patients, here's 5 pamphlets on these DMTs, pick one. I know some people still do that. That's, I don't think, the best way to do business. The one part of this decision making is we have to risk stratify these people. We can stratify people into low risk for disability, high risk for disability. There are studies that substantiate some of these risk factors, such as relapse rate in the first couple years. I mean, if they have a high rate of relapse initially, they're a higher rate of disability. If their recovery from relapse is incomplete, that's a poor prognostic indicator. MRI measures like black holes, T1 hypointensities, the T2 lesion load has correlated, but I would say, the location. So infratentorial, brainstem, cerebellar lesions, and spinal cord lesions certainly are put that person at a higher risk. There is evidence that ethnicity, so Hispanic, Black Americans seem to be at higher risk for more disability. And you could definitely think of socioeconomic status on there, just people in general with not good access to care. Certainly may be at a higher risk for disability for a number of reasons. So when we're sitting in front of somebody, I'm kind of going through this in my head, just, very quickly. And you get a sense of, you mix all this stuff together like in a bowl, and, you get a sense of, is this person high risk for disability or low risk? And that does help kind of guide your decision as to how do I want to treat this person, right? And that's what this slide, you don't have to read it all, but that's what this slide is trying to drive home, which is what's the best way to treat somebody with MS? In years past, and still for many, you start with a platform therapy, maybe an interferon, glatiramer, Tecfidera, Gilenya as opposed to. You start with one of these platform drugs, and then you treat them, and then you monitor, and if they have breakthrough disease activity, then you switch to what you think is a higher efficacy drug. So that's called escalation therapy. But there's another approach, which would be, starting with high efficacious therapy, such as Tysabri or ocrelizumab or ofatumumab or Kesimpta. And I think more and more people are doing that now, starting with high effective therapies right away. And then if they break through, you go ahead and switch to another high efficacy. I think the next step is where we probably need to get to more often. And some of us do this, but I would say the majority don't. So this is the idea of induction versus escalation. So the idea of using 3 of our highly effective options that are more depleting of parts of the immune system and then allowing a repopulation or reconstitution. That includes cladribine, alemtuzumab, and then you would put hematopoietic stem cell transplant in this list as well. And the idea is that you hit it hard from the beginning, you knock it down, you monitor for the next several years, and then if you see there's disease breakthrough at some point, say beyond 4 or 5 years, then you look to go ahead and, maybe you do it again, right? Cladribine, alemtuzumab, or maybe that's when you switch to a highly efficacious therapy. So that's the idea of induction initially, like you would for chemotherapy for breast cancer, as opposed to escalation therapy, which has been the way most people practice. There is a trial we're involved with, along with Hopkins, that hopefully is going to answer the question of, is the escalation approach just as good as starting with a highly effective therapy right away, right? So if you take 100 people and you put them on Tysabri or Ocrevus right away, and you compare that to a population that goes on Gilenya or Tecfidera and Copaxone right away, is there truly a difference between these two cohorts 2, 3, 4 years down the road in terms of our standard metrics, disability levels, relapse rates, MRI changes? This continues to be a debate. I think most of us are treating MS with highly efficacious therapies right away. But this trial, called Treat MS trial, is a trial that's looking to answer that very question, assessing the efficacy of highly effective therapies right away versus starting with escalation therapy, and then when they have breakthrough disease, increasing to a higher efficacious therapy. So we're almost done enrolling. Hopefully we'll have a report out 4th quarter of 2024. And so this trial certainly might change or make people feel more comfortable starting with cladribine right away, starting with Ocrevus or Tysabri right away, and it become more of a standard of care. So lastly, what I alluded to before is, the most important thing with making these decisions about treatment is you really need to do it through shared decision making. There's there's from my side, the provider side, assessing their risk based on their attack and their MRIs. There's that part in trying to choose a therapy. But then you have to look at from their side, the patient side as well. You know, what are they looking for from their treatment? What matters to them? What's their risk tolerance? You know, some people, if you tell them like you could get a pimple, they're like, nope, I don't want it. And other people, they could be like, well, it might cause cancer, but they're like, I don't care. Just keep me doing well. So you have to assess the person's risk tolerance. That plays into it. So there's a number of these factors, right? Economic factors, financial factors. I try to do this through a discussion, right? You try to be as efficient as possible because you don't have all the time in the world to do this, to come up with an individualized treatment plan for that patient. So that's really the way we should be doing this. Admittedly, it takes time, but it's the way it should be done. And that concludes. Thank you very much. Open for questions.
Dr. Silverstein, thank you very much. It was a great talk, great overview, because I mean, it's obviously the more and more we know, I guess more and more questions also arise about the actual disease, about the disease development and treatment, which is neurologists are all exploding, and neuroimmunology is one of the proofs of that. You know, that it turned from diagnostic specialty to truly therapeutic interventional specialty. But anyway, we have several questions for you.
Perfect.
Radiologically isolated syndrome. Okay, so there are a couple thoughts. We have a couple of ways of thinking. That one thing is obviously if there is no clinical presentation, there is no treatment. Another school of thought is, well, it's just maybe the brain parts that were hit that are not that obvious or blatant clinically. And if you really test those patients, you'll find some executive problems or anything like that. So is it really truly just a radiological phenomenon? And that brings to the, to treat or not to treat these patients. Is there any role of these neurofilament lights, your chain evaluations, to make a decision, to treat or not to treat? Where overall the MS world stands with that right now?
Yeah, excellent question. I think the simple answer is, my opinion is, the answer is yes. I do think that a good percentage of these people probably do need to be treated. It's just we don't have the data and ability to go ahead and for sure say that it's definitely MS and they're definitely going to have an attack. One of the hardest things to do is take somebody in front of you that has RIS, it changes on the brain, they're asymptomatic, and to subject them to indefinite treatment. And I always tell them, I always present it this way, if I think they need to go on treatment, and I'll tell you what it would be for me, I always tell them, understand, it's going to be 5 years from now. And when you're doing still really well and you've had nothing, we're not going to know whether you wouldn't have had anything or whether we intervened and we prevented. We just won't know. I think that's where biomarkers are going to be really, really helpful, because if you can show there's evidence of neuroaxonal injury, a baseline, and then it's increasing these, say, NFL levels, I think we'll start to feel more comfortable, okay, we're treating to target, right? We're treating to target. For me, and I have treated RIS a number of times, for me, there's two aspects. One, you are 100% correct. If you look hard enough, I don't know what the percentage is, but I'm sure it's 10, 20%, maybe more, of these people that are RIS. If you look hard enough with sensitive testing, you might pick up on some subtle abnormalities, right? Whether it's executive function or endurance levels. For me, it's spinal cord lesions. So if they have demyelination in the brain, I always get CNT spine. If they have clear evidence of demyelination in the cord, that ups the ante, risk stratify them. They're at higher risk for me. I am definitely talking about treatment. As long as I rule out other explanations, I don't even always do spinal fluid. If it's classic imaging, the spinal cord for me is the big one. And there's definitely studies that have shown that if you have spinal cord lesions in RIS, your risk of conversion to definite MS within 3 to 5 years is 85%. So it's a much more sensitive measure of conversion to having an actual attack.
And that is not the case when you have a clinically isolated syndrome. I think there is no discussion anymore right now. Clinically isolated syndrome, you are ready. But how aggressive are you treating these patients?
Yeah, good question. And again, some of that is philosophy of treatment, right? What is your philosophy? I mean, like you said, if you believe that there's a smoldering inflammatory process happening that could be stimulated by peripheral immune cells getting activated, entering the CNS, so you want to shut that down, it probably makes the most sense to treat with the most effective drug up front that you can use safely in that person. And so, yeah, CIS, their first attack, or it's the first attack they meet criteria for MS, I'm using cladribine. I'm using Ofev B-cell therapies, ocrelizumab, ofatumumab. No doubt. I mean, almost exclusively, I'm treating people with these high efficacious drugs right away if I think we can use it safely and monitor them safely.
Listening to you today just crossed my mind. When we were residents, especially summertime, the MS exacerbations, the hospitals were overloaded with those patients. When you're in the hospital right now, you rarely see MS exacerbation anymore. It's really the treatments are so effective that it really keeps people, at least from the clear-cut exacerbations. I mean,
yeah, or at least the attacks. We know that attacks on treatment, especially highly effective treatment, tend to be more mild than attacks off treatment. And so you're right. At least we're tending to treat these people as an outpatient, right? They don't need to go to the hospital. Many of the things you see in the hospital now are actually like they're more pseudo exacerbations, right? They have COVID and they have fever, or they have a UTI and they're in there with recrudescence of symptoms. So there's no doubt we're seeing less admissions, and we're seeing, I think, less wheelchairs. But that's, yeah, most people do believe that.
Do you have any thoughts on using low-dose naltrexone as an immunomodulatory agent in combination with vitamin D and other DMTs? There is evidence of it slowing disease progression both clinically and on MRI.
So no, there is no good evidence of it slowing disease activity and MRI metrics with LDN. There's no good level 1 evidence for that, period. LDN has had a sort of a cult following, if you will, I think, right, since the 1980s in New York City, when it was being used in the AIDS population and then started being used in autoimmune diseases like lupus and MS. And it definitely has had a cult following since then, with some basic science research there that you can, it's out there, no large trials. There is evidence that low doses of naltrexone seem to, in a couple ways, there's evidence that increases natural production of glutathione, like it might have neuroprotective aspects. So that's attractive if that's true to any neurodegenerative disease, right? But it also seems to have an impact on toll receptors, I believe, on Th1 cells. And oh, by the way, toll receptors on microglia. The microglia story is evolving here, right? And so there is some evidence that LDN might help downregulate microglia. And if that's true and translates clinically, could it reduce some of the progression that we see, or silent progression? Do I use it? Yes, from time to time I will use it. It just falls into one of those categories of like, we just don't know enough about it. Have I picked up a signal, like convinced that it's actually helping? Not sure about that. But it's very well tolerated. It's extremely safe. I don't see why not try it in anyone, but especially somebody who might be noticing some subtle progression.
I've mostly gotten away from the original platform DMTs, injectables like Avonex, Betaseron, et cetera. Is there really a reason to still for these medications? Is there a good case scenario to use them?
I mean, I think with all those DMTs, there's a niche for all of these. There's a patient for all of them, as I say, right? Like if you can't find a DMT for somebody nowadays, like you've got a problem. So is there somebody for Copaxone, glatiramer, or the interferons? Yes. Maybe it's that RIS person without spinal cord lesions. Maybe you did spinal fluid and they have bands and you're like, but they're good. maybe you talk about putting somebody like that on interferon and Copaxone, right? Maybe that's more attractive. I think there's some niches like that. If it's definite MS, they've had an attack, you're at that stage. It's not prodromal, it's not RIS. For me, there's really no role other than the patient has such a low risk tolerance to anything that messes with the immune system. That patient, maybe you put them on Copaxone, right? Other than that, I don't think there's many other situations for it.
Some neurologists still use monthly pulse steroids. Is that even a management right now acceptable based on everything what we know?
No. Now, but I shouldn't say no outright, right? So there again, maybe there's a niche patient population, right? That maybe that might fit for it, but I don't think the long-term risk of that and the known benefit of this, I don't think the benefit outweighs those risks. We know what the risks of frequent corticosteroids are, and it's certainly not as effective as our highly effective drugs. So not ideal.
Okay.
Yeah, just like, where we trained, I mean, I didn't realize it wasn't a thing until I left there and went to UT Southwestern and went to practice. Like plasma exchange.
Yes.
Every month or every 3 months. Oh
Yeah.
my God. Right? Like, wow, I couldn't believe that we were doing that in a population of patients. That too is not something that is standard.
All right. We're at the time, but I'm gonna squeeze in 2 more questions. Your thoughts about ketogenic diet in MS?
So, no hard evidence, just like with any diet, right? There's not a ton of evidence. Mediterranean diet probably has the best. Ketogenic, I don't know that there's enough to even comment on that.
Okay.
Right. I just like fasting. I mean, I'm a fan of time restricted eating, intermittent fasting, having fasting periods, whether it's every day or full fasting once a week, to try to promote autophagy, clearance of dysfunctional cells. And there is some anti-inflammatory effects during fasting, but completely eliminating, right, carbohydrates, or at least below 20 grams a day. I just don't know. I mean, is it reasonable to try somebody that has a lot of fatigue just to see if they feel better? Sure. But otherwise, I don't know.
And when you look evolutionary, we were created to eat carbs. We have the machinery for that. But,
we have the machinery for it. Yeah.
Yeah. All right. And one clinical scenario. I know you did a nice overview of generally how you're choosing the medications, but here it is. Your classical 32-year-old female in your office, no significant past medical history, because except you're diagnosing with MS, moderate risk tolerance. What's your thinking process about choosing the treatment?
Yeah. So number of factors. You're risk stratifying her based on her MRIs, right? If she clearly has a high lesion load, spinal cord lesions. Did you say she had an attack? Classic.
Yeah.
So where it would be easy, where it's easy, is if she's black, she has cord lesions, she presented with motor symptoms or cerebellar, and she's not fully recovered. She's going on B-cell therapy, Tysabri. I mean, heck, I would even consider HSCT if we had easy access to it, right, for the insurance. Okay. But no doubt, she's like highest risk. For me, that's easy. If it's a white female, had optic neuritis, she recovered fully, has just brain lesions, cord 1 lesion or normal, more of a standard kind of lower risk. My philosophy is that person's going on highly effective therapy right away. But I'm going to get a sense of, is she looking to get pregnant soon? What is her risk tolerance? Does she care about like pills or needles or infusions? I try to kind of whittle it down, but my default is I'm starting with an infusion therapy, or even I've used cladribine, Naviclad, first line. First line. I'm just by default, and I've always been this way, but I'm treating with highly efficacious drug, even in mild patients. And this Treat MS trial, as I said, hopefully will elucidate like that this is the right thing to be doing.
Dr. Silverstein, it was really a great talk, and I am getting many comments thanking for arranging this talk. For all the listeners, I would like to invite everybody to come back in 2 weeks, where we'll have Dr. Carsey giving grand rounds. Again, Dr. Silverstein, thank you very much, and everybody have a good Friday.
Thank you. Have a great one.
Bye.